Good evening, everyone, and welcome to our IVF webinar tonight. myfertility.com. This is our site. We are part of European Fertility Society, and we are very excited and happy to be back once again with Dr. Elias Tsakos. You can see him right here. Hello, Dr. Tsakos. How are you feeling tonight? Wonderful to have you back.
Hello, good evening, everyone. Good evening, Caroline. Thank you for the invitation once again, and thank you for giving me this amazing topic to discuss. To be honest, it's one of my favorite topics because success story is always something that our patients need to know about. And of course, success is always made up of small failures, our patients' failures. And I'm very, very delighted to share some amazing success stories with you tonight.
Wonderful. We are definitely eager to hear it. And I've seen the presentation. Dr. Tsakos has prepared some clinical cases. And as you know, this series is all about success stories. It's all about clinical cases, real patient stories. So I'm glad that we will discuss those stories tonight as well. And let me just mention that if you have, I see that someone wrote, there is no sound, please refresh, okay? It should help. If not, you can double check if your browser is Google Chrome. It's the best one to use. So just check it. Okay. I will write this in a second, of course. And let me just briefly tell you that, of course, we will start with the presentation, and afterwards there will be time for your questions. Remember, you can simply put those in the chat section, and Dr. Tsakos will answer them for you one by one. Let me also mention that Dr. Tsakos, he's the medical director at EmbryoClinic, which is located in Thessaloniki in Greece. And Dr. Tsakos has been with us before. He has vast knowledge, and he has over 30 years of experience in IVF field, of course. So it's wonderful to have such a great specialist, as always. Dr. Tsakos, I will leave you to it now. Let's go ahead with our presentation tonight, okay?
Thank you so much, Caroline. And it's a bit scary when I hear that 30, but it's actually true. Some days ago, one of my pension schemes expired, and that made me realize that time is going by. However, thanks to the feedback we get from our patients and from our colleagues and from the people I work with all over the world, I hope for another 30 years ahead. So thanks to a little bit of lifestyle issues that I would like to share with my patients as well. Keep your mind and body healthy. Keep exercising, wake up early in the morning, don't drink too much. Smile, keep happy, smile to your pet, smile to your partner, smile to your neighbor, smile to the taxi driver, even if they're stroppy. I think these are some of my little tricks of keeping healthy in mind and in soul. I hope I should be here 30 years on to ensure that this has proven to be effective for another 30 years. And trust me, there's no secret to living longer and to being healthy. And there's only one secret: find a purpose in life. And I've been fortunate enough to find my purpose very early and enjoy that every day and every night. So I'm not going to bore you too much again with introductions. I will speak about recurrent miscarriages and success stories. This is a nice topic, but it's also very difficult. So addressing an audience, a general audience, and not a medical one, of course, is a little bit of a challenge. So I try to focus on 3 cases that I've treated in the last few years, and I will try to pass on some messages. So let's move on. Most people know that I've been around for a long time. I'm registered and licensed to practice in Greece, the UK, and Cyprus. And I have been fortunate enough to be a member of many societies and many associations, and most importantly, to interact and treat patients from more than 40 countries now. We've added Slovakia recently to our country list, and we've added Ethiopia. We had a patient from Ethiopia last week. So there's a lot of people from a lot of countries giving us the opportunity to share our knowledge and experience with them. And the majority, if not all of them, that managed to create families. So I will go straight into the topic. Recurrent miscarriages. The definition is miscarriage of 2 or more. And of course, they have to be addressed by a specialist team. They have to be addressed holistically, and they have to be addressed systematically so that we don't miss anything out. Of course, if we add in 2 more factors into the recurrent miscarriages, and one important factor is the age. So the value or the importance of a miscarriage, of course, is different if someone is miscarrying at 25 and if someone is miscarrying at 40. And that reflects on the level of investigations we would probably initiate. And also, there's another concept, which is recurrent IVF failure. So it's not just the miscarriages that should be investigated, but also if someone has 1, 2, 3 failed IVFs, that interacts with some similar factors many times with miscarriages. So I would like to be very schematic, and I would like to give you some images tonight so that you remember them. So female anatomy. This is a beautiful image of the internal female anatomy. So we can see the uterus, we can see the fallopian tubes, and we can see the ovaries. Now, there is a misconception that the ultrasound scan is the gold standard in diagnosing female anatomy. So we have to be aware that this is not true. The ultrasound scan is a very important tool. Technology is getting better by the year. I remember when we started about 30 years ago, there's no comparison to what we see now with the 3D and 4D ultrasound scans. However, it is not the gold standard. So please remember that your female anatomy cannot be thoroughly assessed by means of a scan alone. A second misconception is that the tubes are not necessary or they're not important if we're doing IVF. That's wrong. They may be important because if the tubes are seriously affected by infection, and in particular if the tubes suffer from a condition which is called hydrosalpinx, which is a big infection that's causing fluid and toxins to accumulate within those tubes, they may affect both the success of IVF but also the outcome of a pregnancy, so they may cause miscarriage. A third misconception is that we don't care about conditions like endometriosis, or we don't care so much about conditions within the uterus when we're having IVF or when somebody is conceiving naturally. This is not true. So female anatomy is very important. I think this is the take-home message. And the assessment by ultrasound scan, no matter how high-tech the scan is not 100%. So please keep that in mind, and I will come back to it. So my first case, and I don't know if Dave Gibbon is listening to us. Dave is a consultant embryologist. He is the heart and soul of EmbryoClinic in the UK. And interestingly, this was one of his patients roughly about 7-8 years ago. That was a lady in her mid-40s. I will not tell you the whole history. However, what I have to tell you is that she had lots of miscarriages and lots of failed IVFs. And what was the cause? The cause was a uterine malformation. I will try to keep it straight to the point. Uterine malformation is conditions that some women are born with. The commonest one is this. Here you can see a normal uterus on the left. Can you see my pointer? I don't know if you can see my pointer. Anyway, on the left of your screen, you can see a normal uterus.
Dr. Tsakos, apologies. Yes? We cannot see the pointer, but if you can click on the arrow in the middle, there is the second option pointer.
The arrow in the middle.
Next to the green square.
Okay.
Sorry, at the bottom, next to the green square, there is an arrow.
Okay, I'm getting
And if you choose pointer, the second option, it should work.
Okay, I'm with you. Brilliant, lovely, thank you. Can you see it now?
Now it's all good. Yes, we can see that.
Excellent, lovely, thank you very much. So this is a normal uterus. This is normal everything, by the way. Now, this is a normal uterus, so we can have we have a normal cavity of the uterus, which is called endometrium. This is an abnormal uterus, and this is a uterine malformation, one type. There's a lot of different types of malformations, but this is a fairly common one amongst the infertility patients and amongst the patients with repeated miscarriages, which is called either diaphragm, uterine diaphragm. Most people would call it this, a uterine diaphragm. There's different terminologies. I will try to keep it simple. So as you can see here, instead of having one cavity, we have two smaller cavities. So there's a division of the cavity into two. So the first case I will talk about is a case in her mid-40s. She was thoroughly investigated. She had lots of scans by lots of different doctors. She'd had miscarriages and failed IVFs. And the problem in that lady was this diaphragm. And in actual fact, there's other images that I haven't included, which show how this diaphragm was actually coming further down into the vagina as well. So this lady came up to the age of mid-40s without knowing that not only did she have a double uterus, but she'd also had a double vagina. So what we did was we corrected this malformation surgically through hysteroscopy, and then this lady underwent successful IVF, and she delivered beautiful twins who are growing nicely somewhere in England or Scotland at the moment. So please bear in mind that if you do have a problem with miscarriages or failed IVF failures, do not rely on the scan alone, and do request to have further investigations to ensure that you do not suffer from a uterine malformation. Second case, again, they've given us a patient who attended our clinic with a history of recurrent miscarriages, and we diagnosed hydrosalpinx. Hydrosalpinx, there's a bad spelling here, wrong spelling. It's all Greek. That's why most people spell it wrong, including myself. So hydro is water, salpinx is tube in Greek. So what is it? It's a condition in which there's fluid accumulated in the tubes. Now, what is this image? This image is an X-ray HSG, an X-ray hysterosalpingogram. There is a lot of literature proving that it is important to exclude hydrosalpinx prior to doing IVF or prior to completing our miscarriage investigations. Now, this lady sadly didn't have that, so she underwent treatments, she had miscarriages, she came up to her mid to late 40s before she found out that through the X-ray HSG that she had hydrosalpinx. Now, again, I have to stress here that in most European clinics and most US clinics, an X-ray HSG is not one of the standard tests prior to IVF and may not even be a standard test after a miscarriage or miscarriages, and may be substituted by either a high-tech scan, ultrasound scan, or an ultrasound-aided tubal assessment, which is called HICOSI or HIFOSI. Sadly, HICOSI and HIFOSI and high-definition scan are not 100% accurate in diagnosing hydrosalpinges. So please keep that in mind in cases of miscarriages or in cases of failed IVFs. Perform a standard X-ray HSG, and if you diagnose a hydrosalpinx, remove it laparoscopically. That lady of ours, she'd had laparoscopy to remove her tubes because they're no good if they're there, and then she'd had two beautiful children consecutively, not at the same time, through IVF, and now she's growing two beautiful children at home. So please bear in mind the possibility of hydrosalpinx in case of miscarriages. And again, some people do not quite grasp that there is a possibility of conceiving naturally, even with a hydrosalpinx in place. However, there's increased risk of both miscarriage and ectopic pregnancy. So again, a few words about hydrosalpinx. It's filled with liquid. You can take screenshots if you like of this slide. The tube is partly or partially or totally blocked, and this is causing misdiagnosis many times. There's a lower chance of pregnancy and increased chance of miscarriage and ectopic pregnancy, and you can see what it looks like. It may be unilateral, it may be on one tube, or it may be on two tubes, on both tubes, and if the hydrosalpinx is of high degree, the solution is removal via laparoscopy. And my third case, which is also, again, very interesting, this is not one of David Gibbons' case. This is a case we treated recently. That was a lady with recurrent miscarriages. The problem with recurrent miscarriages is that the miscarriage itself and perhaps the DNC, the surgical evacuation, or even the medical evacuation may cause an additional problem, which may be the endometrial adhesion. So one of the reasons why we don't really like many miscarriages is that despite the origin and the etiology, despite the reason why a couple miscarry in the first place, the miscarriage itself may cause damages may damage the endometrial cavity like it did in this case, and cause this band of tissue, which is scar tissue, which then again aggravates and increases the risk of miscarriage. So that was a case of endometrial adhesion that was successfully divided and led to a natural spontaneous pregnancy following that. And this is only one example. Of course, we've had lots of similar examples. Now, so these were my interesting cases, and I would like to highlight the importance of anatomy assessment. The anatomy of the female is very, very important, but of course other factors are important. So I'm giving you a little outline of the main reasons for recurrent miscarriages or recurrent IVF failures. One is the hormonal reasons, and of course here we may have some defects, thyroid defects, polycystic ovaries may be linked with miscarriages. Anatomy defects like we described earlier, or on top of those I would add the endometrial polyps that could be in the cavity. I would add fibroids, either big fibroids or smaller fibroids that affect the cavity. Genetic causes may cause miscarriages, so we always suggest the karyotype testing of both couples. In actual fact, in my practice, I always perform karyotype testing prior to any intervention, any IVF procedure, because I feel that the patients that eventually come to an IVF clinic, they're not the standard cohort of patients in which karyotype disorders are uncommon. So we do identify quite a few patients every month with karyotype aberrations that are not aware of, male or female, and even cystic fibrosis genetics may affect the miscarriages. Infections, I think most people would agree that they have to be ruled out, and I'm talking about both serological blood testing that may identify infection, and of course swabs, vaginal and cervical swabs. Screening for medical conditions is important, undiagnosed diabetes or starting phases of diabetes mellitus, sugar diabetes, conditions like lupus, etc. And other factors like lifestyle issues that I mentioned initially may affect the fertility potential and also increase the miscarriage rate. Heavy smoking, alcohol consumption, or drug consumption, and of course medications also may cause miscarriages. And also, if we've excluded those important issues, we can always think of unexplained factors, but indeed, if we thoroughly rule out the majority of factors, in the majority of situations, we may identify a reason, and we should be able to treat it accordingly. A few words again about fibroids that I mentioned before. Fibroids are very common soft tissue tumors. The vast majority of those are benign tumors, although some of them may become malignant even in younger patients, in patients under the age of 50. This year we had a sad case of a lady with a very small fibroid. It was less than 3 centimeters. It was not even touching onto the cavity, that ended up being diagnosed as a sarcoma, which is a malignant fibroid tumor, and the lady had to undergo a hysterectomy. And she felt very lucky that that was diagnosed prior to IVF, because you can imagine she'd had lots of miscarriages before. If that lady got pregnant through IVF, the tumor would have been undiagnosed for at least 10 months, and that would have been absolutely detrimental for her health. Now, with regards to miscarriages, can you see my pointer now? I presume you can. Here, this fibroid may affect and may cause, may be associated with the miscarriage. This one also. These ones are not associated with miscarriages and are of no importance unless they grow fast or they become bigger than perhaps 4, 5, or 6 centimeters. The diagnosis is usually done by ultrasound. However, if we want to ensure that the cavity is normal, we still need to do hysteroscopy and decide if those need to be treated or not. Now, do not forget the men. Don't forget the men. Don't forget the male tests. Don't forget that men can also contribute to the etiology of miscarriages. The miscarriage of the fetus of the baby could have a male factor behind it. So these are the tests that I would recommend on men as well in case of miscarriages. Recurrent miscarriages, semen analysis, semen culture, genetic tests like karyotype or cystic fibrosis, some viral tests, microbiology and viral tests, hormonal tests on the male, and more specific genetic tests like DNA fragmentation and Y microdeletion tests on the male. So please remember fertility endoscopy in the diagnosis of miscarriages, and the gold standard in diagnosing the endometrial lining. And this is now becoming more and more a routine test on almost everyone who is attending a fertility clinic with a history of either miscarriage or prior to embarking on IVF. It's an outpatient procedure, it's inexpensive, it's highly accurate and diagnostic, and it's giving us the confidence we need. Our patients and we need the confidence prior to embarking on a next pregnancy. And the value of hysteroscopy has been proven and scientifically discussed. This is my city, Thessaloniki. I invite you all to visit us for holiday. And in terms of fertility, of course, you're welcome, but please get in touch with us first because we may be able to help you without the need to travel. It's a beautiful city by the sea with wonderful scenery, wonderful mountains nearby, wonderful beaches, and most importantly, wonderful people like the people that work with us at EmbryoClinic and who would be delighted to assist you in any possible query you may have online or on site. Thank you so much for listening. I didn't take too much of your time because I'm absolutely thrilled and waiting for questions now, and I hope I should be able to help some of you find your way and direction into the parenthood. Thank you for listening.
Indeed, for again sharing your experience, but also sharing, of course, those cases. And of course, as you can see, there is first question right here. So let me just repeat this. Now it's time for your questions, so don't hesitate. Dr. Tsakos is here to help you out a bit, so go ahead. And the first question, it's a bit of a longer question. Let's go ahead with this. Just a second, though. Okay, here it is now. So I am 41 years old and I have had a miscarriage at 8.5 weeks when I was 38. Following that, I was diagnosed with thrombophilia. Some doctors agree this might have caused my miscarriage, others don't. I'm currently doing IVF. Would you recommend doing any treatment to help prevent further miscarriages? Also, would you recommend using own eggs? I have 2 grade 1 frozen embryos so far, or egg donor. My AMH is 2.59 and FSH 2.6.
Sure. Hi, Christina. Thank you for very, very nice summary of your situation. I mean, I would be very optimistic. I mean, definitely use your own eggs. 38 is young. Your AMH is fine. You have embryos. You've been pregnant before. Go ahead, use your own eggs. I'm sure you will make it. I mean, even a miscarriage at 8.5 weeks is a slightly positive sign that you can make it. You can get pregnant. So definitely use your own eggs. Definitely keep going and keep trying. Now, thrombophilia, definitely get treatment. I mean, I'm not going to go into details, but thrombophilia is maybe one of the important reasons for miscarriages, for recurrent miscarriages, for pregnancy complications, and and health issues in the future. So there's different degrees and different variables in diagnosing thrombophilia. However, if it has been diagnosed, there's no harm at all preventing any possible contribution of thrombophilia in your pregnancy by taking a small dose of low molecular weight heparin based on your weight, and also perhaps a small dose of aspirin. So definitely get some prevention treatment for that, intervention for that, which I would probably continue up until 12 weeks and then reconsider whether I would use it for longer. So definitely low molecular weight heparin and aspirin, and keep going with your own eggs. 2 grade 1 frozen embryo would probably give you 1 or 2 beautiful children. So please let us know when it's happened, and I would highly encourage you to keep going.
Excellent. Thank you so much for the very first question, and of course for your help as always, Dr. Tsakos. I do believe it has been useful for you, Christina. So yeah, as you can see, there is a thank you from Christina. Someone is typing. We just need to give it some time and have a look at the question. So just let's have a look. Let's give it a second.
Sure. Before, just to take advantage of the time, please use some of those tests as a guide for baseline tests and assessments prior to perhaps seeing a specialist or prior to IVF. It is very important for me, for any couple with a fertility issue, to design a protocol and a strategy of investigations. I think that in general, we do not investigate enough our patients. Perhaps we are just stuck a little bit with protocols that we used in the past. We're stuck with beliefs that the tests are very expensive. We should not make decisions on behalf of our patients. This is what I feel. So, and that's why my team and I, we have created in terms of pre-IVF tests, a very useful form. It's only one side of A4 of the absolutely obligatory tests that everybody should have. For example, everybody should know, all fertility couples, they should know their blood groups, perhaps. Some standard things like the full blood count. They should know whether they're carriers of thalassemia. Maybe a karyotype or cystic fibrosis wouldn't harm. Standard tests, some standard viral testing, toxocy and rubella for the female, and of course, or the infection screen for the male and the female, HIV, hepatitis, hepatitis B and C, and syphilis. So standard tests should be done, in my opinion, by all couples. And then we have the highly recommended tests, like the tubal assessment, perhaps a hysteroscopy, some male tests, a little bit more advanced male tests. We tend to ignore men. We rely on just on a semen analysis, and even if the semen analysis is not perfect, we say, okay, don't worry, we'll do ICSI. It's not as simple as that. So sort out some basic tests before you move on to the next step. Right, so we have another question now.
Thanks so much, Dr. Tsakos, for adding this as well, of course. And as you can see, another question from Alison is here. So is there a difference in the success rate of a frozen embryo transfer versus a fresh one using donor eggs?
Frozen versus fresh one. Okay, I will tell you my experience in this, and I will tell you the challenges. And I will tell you why in our practice we only use fresh eggs from the donor, frozen sperm from the husband or partner if there's a couple, or frozen donor sperm. And we always do frozen embryo transfer of the blastocyst, okay, which is one of the 3 options that egg donation programs provide to the patients. We have audited the other options. What are the other options? One option is fresh collection, egg collection from the donor, and fresh embryo transfer. The second option is frozen eggs from the donor and fresh embryo transfer. And the third is what we're doing. Now, what is the challenge of using fresh eggs from the donor and fresh embryo transfer? There's basically two challenges, which are becoming even more complex now with the COVID situation. When we match a donor, the donor, once they're matched, they also state when they're available to do the IVF. So, you know, a perfect suit for Alison, perhaps, would be donor number one. However, who would only be available for an egg collection in December or end of October because of other commitments. And Alison may not be available to travel for her treatment those days. So there's not always there's very commonly a discrepancy between the availability of one or the other. So this is one challenge. Second challenge is, okay, the donor is flexible, they can do the stimulation anytime. Alison, the recipient or whoever the recipient is, they're flexible, they could come out anytime. So we'll try to synchronize them. Synchronizing a donor with a recipient has a chance of perfect synchronization of about 80% only, not 100%. And what do I mean by saying this? In order to synchronize, you would have to have medicated cycles. So we would have to medicate you so that you go parallel. However, medication is not always 100%. And plus or minus 1 or 2 days in the egg collection and in the embryo transfer may have a huge impact on the success rate. So that's number 2 factor. Synchronization, which at best is 8%. Number 3 factor is experience, is the patient experience, the donor experience as well, and the clinic experience. When we stimulate a donor, when we stimulate a patient, when we prepare a patient for embryo transfer, we're stressed. We're almost as stressed as you are for different reasons, okay? So we want everything to be perfect. So you can imagine the stress, and we measured all of that. My team and I, we've audited the stress levels, and we found that when we were trying to synchronize the cycles, our patients were very stressed, our donors were very stressed, and the clinic staff were very stressed. And this affected the experience of the team. Why were we stressed? Because we wanted not only the donor to stimulate perfectly and create perfect eggs, but we had an extra added stress of the time. Was that going to be done on time to be in parallel with the recipient? And then we found that some recipients, they take longer time for the endometrium to be perfect. Some of them took 11 days, some of them took 15 days or 17 days. So when we had to trigger what cannot wait once the synchronization process starts, the trigger cannot wait more than 24 hours. Okay, so then we had to cut corners. We had to decide what to sacrifice. Would we sacrifice the endometrium and the implantation success potential, or would we sacrifice the quality and the quantity of the eggs of the donors? So that was too much. And on top of that, we found that the success rate was about 10% less with synchronized cycles, unfortunately. The stress levels were much higher, and also the matching was not brilliant, because we found that the recipients who were traveling from Europe, from the UK, from America, from Australia, we found that they would rather compromise the donor than compromise themselves, of course, because they only had very limited time. So we stopped that, we dropped it. So if you ask me, in our hands, now frozen eggs, again, huge challenge, because an egg is only a potential embryo. What does that mean? It means that you may thaw an egg, or 6 eggs, or 10 eggs, or you may have 1 embryo, 2 embryos, or no embryos of top quality. So by disconnecting the treatment cycle with the embryo transfer cycle, we disconnected the timing, the availability of our patients. We disconnected the stress, so we only had focused stress on one at a time, on the donor initially and on the recipient afterwards, and we can handle that, and our patients could handle that. And we also ruled out the 10% chance that for some reason the donor didn't go well. Because some donors, they don't stimulate well, we have to cancel them, or they stimulate relatively okay, but they don't create good eggs or mature eggs, or they create very good eggs, but for some reason the eggs, they do not connect very well with the sperm we have available, and therefore we have no embryos, or we only have one embryo, in which case we probably cancel the cycle and we run another donor. So for all those reasons, in my practice, in my experience, I discourage anything except using fresh eggs from the donor, creating the blastocysts so that we know we have the blastocysts. We say goodbye and thank you and goodbye to the donor, and then we focus on the recipient so that we make perfectly the preparation of the recipient, having got the blastocysts in hand and providing them with 1 or 2 top quality blastocysts at a time.
Excellent. Thank you so much for bringing this question indeed, because it's always an interesting question, and we could discuss it. It could be another webinar on that, I'm sure, right, Dr. Tsakos? So thanks so much indeed. And let's have a look. As you can see, Dr. Tsakos, many more questions are coming in right here. So let's get going with the next question. Do you recommend, another interesting one, do you recommend PGTA in embryos derived from donor eggs?
I don't, and it's not legal either in Greece, so so it can be done.
Okay.
PGTA, at the moment, the evidence is that may be valuable for women with repeated miscarriages or women of advanced reproductive age, and in particular over 40 years old. So that doesn't apply. So it has an indication. PGTA is a tool. But it has, if we want to be strictly scientific and not very commercial, we will have to use it with specific indications. And those indications do not apply in the egg donation cycles. In egg donation cycles, our donors are under 30, at least in my clinic, under 30, healthy females with healthy history and so forth. So they do not qualify for the medical indications of PGTA, and the Greek authorities, they have grasped that, and therefore, in order to avoid commercialization of commercial use of PGTA, they forbid that. It cannot be applied. It's not legal to apply PGTA in the egg donation cycles.
All right, crystal clear. Then, of course, thanks so much for explaining. And next question we have. Do you do thrombophilia diagnostic in recurrent miscarriage patient?
Yes, I do is the answer, definitely. Mm-hmm. To be honest, we're very aware. Thrombophilia has become, well, the diagnostics have been now they are readily available. They're fairly inexpensive. We have learned a lot about thrombophilia and the impact on fertility and pregnancy over the last 10, 15 years ago. So we are very well aware that thrombophilia testing and thrombophilia factors may affect the outcome of pregnancy. We know that. And therefore, how do we incorporate this into our practice? Before even a miscarriage, when we do our standard fertility questionnaire and standard fertility history taking, we try to identify any risk factors for thrombophilia. And definitely, because the panel can include quite a few tests, from 1 or 2 tests to up to 20 individual factors that we look at. In case of even a single miscarriage, I usually run a small panel of thrombophilia testing. And in case of more than 1 or 2 miscarriages, I would highly recommend the full panel of thrombophilia testing.
Excellent. Again, thanks so much.
Of course, treat it accordingly with the results. As I mentioned before, with low molecular weight heparin, usually in combination with aspirin.
Okay, and actually, Sebastian has a follow-up. Okay, let me go straight to this one. So, do you do supportive treatments like ASS or heparin or corticosteroid treatments?
Yeah, yes is the answer. Yes, I would.
Okay, thanks for the confirmation to this question. Next question is, after how many miscarriages do you think one should stop IVF treatment?
Difficult question. So presumably you're speaking about miscarriages after IVF. Okay, depends is the answer. I mean, I would definitely exhaust all the diagnostics, as I mentioned before, and reevaluate the diagnostics again, because sometimes, for example, somebody has had an X-ray HSG 4 years ago, and they may, in the meantime, they may have developed hydrosalpinx without knowing, or they may have had a hysteroscopy 2-3 years ago, and since then they may have had a couple of DNCs or an infection that may have affected the endometrium. So I would definitely readdress the diagnostics. I would refresh and perform as much diagnostic tests as possible. And then it comes to the question of age. And it comes to the question of what kind of IVF do we do. So in general, I don't know. I mean, Mina, can you give us your age, or the person you're talking about, their age, please? So that I can be more specific. So anyway, it depends on the age. So if somebody's over 40 and they've had 2, 3 miscarriages, 4 miscarriages with their own eggs, I would start seriously thinking about 2 options. One is performing IVF with PGTA, which means that I would only transfer, 41. If you've had lots of miscarriages, well, at 41, in my opinion, there's 2 options. Once you've exhausted your diagnostics, once you've excluded all the factors that I've mentioned in one of my slides, there's 2 ways forward. One is IVF with your own eggs and PGTA, so that at least you ensure that the embryos you're transferring are chromosomically normal. We call them euploid. And full support, of course, full hormonal support, and maybe low molecular heparin support, and aspirin and steroid support. And the second option would be to move on to egg donation. If you've never had PGTA, and if you really wish to absolutely exhaust the chance of creating euploid, normal, chromosomically normal embryos, I would probably suggest you have PGTA. At 41, I would fight for it. Depends on how you feel. But I would definitely fight for your own eggs.
Thank you so much indeed, of course. And as you can see, there's a thank you from Nina here as well. Let's have a look. More questions are coming in. Next question is right here. I have just had a miscarriage at 7 weeks after getting pregnant using frozen donor eggs. I am 46. This was my second attempt at donor egg IVF. My question is, how do I increase change of getting pregnant and reduce the chance of miscarriage? Next time.
Okay, let me go again. 7 weeks. Right, okay. I would, check the male, check your partner thoroughly. Karyotype, cystic fibrosis, semen analysis, infection screen, general test. Make sure your man is healthy and his sperm is healthy. And then ensure that everything is normal within you. So hysteroscopy, HSG to rule out hydrosalpinx. Check your hormones, thyroid thoroughly, vitamin D levels, infections. Make sure you're fit as a fiddle before you move on. Really, put it this way, frozen. What is acceptable with egg donation, what's not? If we have reasonable sperm and we create top blastocysts, we would expect around 55% pregnancy rate per single embryo transfer. So with 2 embryo transfers, roughly about 75 or 80% of our patients should be pregnant. So the remaining 20%, I think we should heavily investigate. We should investigate. So provided you have top quality, yes, I saw that it's frozen embryos. Provided that you have top quality embryos, I would make sure that the environment is 100% healthy. So hysteroscopy, HSG, hormonal testing, infection screen, and then of course very good preparation of the cycle. Let's not forget that there's various protocols to preparing the cycle. How you take them, is it a natural cycle? Is it a medicated cycle? In the medicated cycle, you take, of course, estrogen. Do you take them orally? Do you take them vaginally? Do you take patches? How is the endometrium forming? Is it normal? Do you measure the hormones as well? Because sometimes there is some sort of hormone imbalance that we don't pick up by just doing a scan. I mean, some people just use the scan, the ultrasound scan, and measure the endometrium prior to a frozen embryo transfer. In my practice, we rely on blood testing as well, on hormonal testing, to ensure that at least that we have some standards, that the estrogens are of a certain level. We try to correlate that with the findings of the endometrium. We want the progesterone to be very low before we start the preparation of the cycle and so forth. So perhaps a meticulous monitoring of the cycle is important. And then, of course, the labs, the laboratory is important. Who is performing the embryo transfer is important. Make sure it's not a difficult embryo transfer. Maybe a small dilatation in a cycle or two prior to the embryo transfer may facilitate. Perhaps getting the most experienced member of the medical team to do the embryo transfer, because we all have a little different results sometimes. So I would encourage you, there's still a chance that you will get pregnant with those frozen embryos, as long as every meticulous detail is looked at.
Excellent. Thanks so much indeed. And as you can see, there was a follow-up right here, and there is the answer. Yes, agreed. Good advice. Thank you so much. We are happy.
Well, I mean, all I have to say is, I tend to resemble IVF with cooking. I mean, there's dozens of tiny little pieces of detail that add on to the puzzle, and anything can happen anywhere. You can have the perfect embryos, and for some reason you may have a difficult embryo transfer, which will compromise everything. Or you can have embryos that are not so wonderful, and for some reason embryos that didn't thaw very well, or they thawed partially, or they didn't expand. There's a lot of factors that may affect success, unfortunately, and that's why it's IVF is a very meticulous work, and we all suffer from a little bit of OCD, attention to detail. We're all a little bit disordered there. Everything has to be perfect, from the perfumes that are not allowed in the OR or in the lab, from the people that we have to have the absolutely necessary number of people, because even breathing through the mask may damage the environment and create volatile objects in the air and so forth. There's a lot of fine detail. We need to ensure that our patients understand the drugs, they take them correctly. We cannot over-treat, in my opinion. So, if you're in doubt about the absorption of the tablets, in my opinion, I wouldn't hesitate to use vaginal or transdermal institution of estrogen. And of course, progesterone is also important. How many days, when we start it, how do we give it, how do we monitor it, and so forth. Plus the support. Of course, there isn't very sound evidence in giving steroids to everyone, or to even some of our patients, or there's no sound evidence of aspirin. We have some meta-analysis saying that perhaps makes no difference, but maybe a subgroup of patients would benefit from that. Recently today, actually, there was a study in human reproduction about the benefit of low molecular weight heparin in case of thrombophilia and all that. I think we must focus even more on the difficult cases. It's just that sometimes in a busy clinic, you cannot focus on the difficult case. You just treat all the same, and perhaps sometimes we miss a little important piece of detail. That's why I think it's very important what you're doing excuse me, with the webinars, because I think our patients need to be educated so that they know themselves. It's not that complicated what to ask for, what to challenge, and what to request sometimes.
And thanks for adding that, for sure. We will be slowly finishing, okay? So if we will not answer all the questions, don't worry. I will forward those to Dr. Tsakos and his team. They will get back to you, okay? And let's have a look, okay? One question is right here as well. Is it true that women are super fertile after a miscarriage? And if this is true, does this apply to older ladies of 45 plus?
Difficult question, to be honest. I mean, difficult question. In terms of age, I'm afraid I have to say that the fertility over the age of 40, the female fertility is decreasing rapidly. Even the male fertility is decreasing after the age of 40, but rapidly so after the age of 50, the male age of 50. Generally, miscarriage by itself is not necessarily an adverse factor, depending on what is caused by. So I cannot answer this question. I mean, all I can say is that over the age of 45, there's a very narrow area of fertility. There's a very, very, very small fertility window. However, we do have a large number of patients in that age group where we have to be very meticulous, and usually egg donation is the way forward. Don't forget that by ensuring that we have a normal embryo, this is only ensuring one of the 50 factors of IVF success. So it's not by itself a solution to all our problems. Of course, it is important, but we have to ensure that the rest of the female organism, the body, is healthy as well. So I cannot generalize. I think we should take things individually. Definitely 45 is the new 35 in terms of many aspects, but I think we should be careful when we're treating women over the age of 40 or 45. Firstly, ensuring that we do not compromise their health, the general health, and secondly, ensuring that we haven't missed out important factors for the IVF success.
Understood, of course. Thanks so much. And I believe that might be our final question for tonight. But as I've mentioned, there are some questions left. If we will not answer those, don't worry. I will forward those to Dr. Tsakos. Okay. And let's have a look. This is the question. So we had 2 stimulations from 2 different clinics, 2 different donors. Both results 20 eggs. Both were NGS tested. One with donor age 24 resulted in 1 healthy blastocyst only. The other one, who is 30 years old, resulted in 6 healthy blastocysts. What might have caused this variation? My DNA fragmentation was excellent.
Sure. Well, various factors, really. I mean, from the egg donor, the first egg donor may have had polycystic ovaries and they may have had poor quality eggs. Or in the first egg donation cycle, perhaps the sperm may have been affected by some infection or by some issue that perhaps affected the fertilization, or it could have been some sort of other issue that it's very difficult to pinpoint, but it's not unlikely. And this is one of the reasons why we disconnect the cycles. So, for example, in my clinic, we would cancel the first cycle. We wouldn't count it at all. I mean, if we create 1 blastocyst, we give the couple the option to cancel at no cost to themselves, and we run another donor because we don't really like that outcome in general. Now, a 30-year-old donor is still a very young donor. So, 20 eggs from a 30-year-old donor is a lot of eggs. I mean, to be honest, again, another issue with egg donation is how do you stimulate your donors and what is that you're after. In general, we don't like to overstimulate our donors. We don't like to aim at 20 eggs. We like to aim at a lesser number of eggs. 10, 12 eggs, in my opinion, is a very good, and we're talking about mature eggs, of course. We may have 20 eggs, but not all of them would be mature. So, these are my comments. Definitely, I think this is proving my point, the point that I made previously, that we don't like parallel cycles, synchronized cycles, because we don't like to be faced with this situation. Synchronized two women from different, in different areas, having all this effort just to produce one embryo. And that's why we would rather stimulate the donor first, ensure that we have at least in a full egg donation cycle, at least 3 blastocysts, and otherwise cancel the cycle and move on to another donor.
Wonderful. Thanks so much, of course, for your question.
By the way, fragmentation is not affecting the outcome of IVF. Presumably, they performed ICSI. That's another issue. I mean, whether they performed ICSI or standard IVF. In my practice, we always perform ICSI on egg donation cycles, just to ensure that we won't have any fertilization issues unexpectedly. So I don't know if they use standard IVF or ICSI in the first cycle, but if they use the ICSI, DNA fragmentation is irrelevant.
All right. Perfect. Thanks so much for adding this. And of course, there's a thanks from Miso for you right here. As I mentioned, there are like 3 questions left. I will forward those to Dr. Tsakos, his team at EmbryoClinic. I'm sure they will be happy to help you out. So thanks so much, everyone, for a brilliant session. Thank you so much for your questions. As always, you put so many interesting questions, and I'm sure Dr. Tsakos appreciates this as well. Thanks so much, Dr. Tsakos. It's always great to have you here. And I just want to mention, don't worry, Dr. Tsakos will be back on the 30th of September. He's back. There is another topic he will discuss. So, yeah, I guess that will be it for tonight, Dr. Tsakos, right? Anything else you would like to add?
Thank you, Caroline. Thank you, everyone, for your amazing interaction and questions. Keep challenging everyone. Keep challenging the knowledge that you have acquired until now. And I look forward to seeing you next time. Keep going. The vast majority of fertility patients, they get pregnant, they create families. So don't give up, keep going. The science is there, the experience is there. I'm sure there's going to be a lot of people willing and wishing to help you create your family. So don't give up. Have a wonderful evening and hope to see you all soon online.
Yes, of course, we will see each other very soon. And as you can see, I have learned a lot from watching these. So I'm very, very happy to see that and hear that. So thanks so much for that. And as you can see, more thank yous are coming up right here. So enjoy your evening, as Dr. Tsakos said. Remember, we will be back. We will be back actually on Thursday at 7 p.m. UK time. I hope you will be able to join us. Another expert, another topic. So I'm sure you will find it interesting. You can go to myivfenses.com and you will find the upcoming events right there. And of course, if you would like to have a look at this webinar, it will be available tomorrow on our YouTube channel as well. My IVF Answers, all you need to look for is right there, and you can find previous webinars with Dr. Tsakos, which I'm sure will be also interesting for you. Thanks so much, everyone. I hope to see you here on Thursday. And Dr. Tsakos, still our next event. We will see each other very soon. I'm already looking forward to this. Thanks so much.
Cheers. Thank you. Bye-bye. Good night.
Bye. Good night. Bye.